Good evening, dear doctors. Today we are going to conduct great clinical episode on our XP Connect webinar education series, powered by Logic Technology from GE Healthcare. Today we have with us speakers who are legends in their field and are great teachers. They will enlighten our viewers on chronic liver disease, elastography, and portal hypertension. A very warm welcome to Dr. Nidhi Bhatnagar and Dr. Sudheer Gokhale. Dr. Nidhi Bhatnagar is from Delhi. She is Principal Consultant in Radiology at Max Multispecialty Center, Delhi, and she is also holding a position of Vice President in Musculoskeletal Ultrasound Society. Dr. Sudheer Gokhale is from Indore and he is currently a Director at Gokhale Sonography Clinic, Indore. And currently he is also a Professor of Radiology at Sri Aurobindo Institute of Medical Sciences. He is member of the Administration Council and member of Education Committee of Asian Federation of Ultrasound in Medicine and Biology. Now I would like to welcome Dr. Nidhi Bhatnagar to address our viewers with her clinical talk. Over to you, ma'am.
Thank you very much, Zeenath, for the kind introduction. Good evening, everyone, and a very warm welcome to all of you who are joining for today's webinar. I am very honored to share the platform with Dr. Sudheer Gokhale, who absolutely needs no introduction, and my heartfelt gratitude to GE Healthcare for supporting this webinar. I will be talking on liver elastography, which is a fast emerging, a very powerful non-invasive tool in the liver fibrosis assessment. A topic of great concern since liver failure in the past decade is on the rise. NAFLD, a major contributor, has 35 to 40% of the world population in its grip. A quarter of this can progress to non-alcoholic steatohepatitis, hepatitis, which is popularly called as NASH, and approximately 20% of this may proceed to cirrhosis and failure. In pursuance of saving lives, it has been conclusively proven that presence of degree of fibrosis is a predictor of adverse long-term outcomes. Very sadly, fibrosis creeps in very silently. So what is it that we need to understand? We need to understand that the disease in liver is often without symptoms. It is very common to learn that a patient has stage 4 fibrosis or impending cirrhosis as first warning, that it can lead to cirrhosis, and cirrhosis is irreversible. Biomarkers or the B-mode grayscale scan do not show the changes till the fat content, which should be about less than 5% of the total liver volume, has risen to greater than 30%. Hence, early quantification and differentiation between early stages carries a significant prognostic implication for risk stratification and patient management. There are several chronic progressive liver pathologies that can lead to liver fibrosis. Alcoholic liver disease and hepatitis C, as you can see in the pie chart here, are well-known causes of cirrhosis and form nearly 50% of the causative reasons. However, management of NAFLD or non-alcoholic fatty liver disease or NASH can be challenging since the pathway of how it leads to failure are not clearly understood. Obesity, dyslipidemias, abnormal metabolism such as diabetes mellitus, hepatitis B, being on long-term steroids, chemotherapy, pregnancy, and underlying genetic diseases such as Wilson's hemochromatosis all contribute to a spectrum of causes leading to fibrosis. Cause and effect relationship certainly has been very clearly understood. Hence, the clinicians do investigate high-risk patients through a series of biomarkers and interval B-mode scans. Yet, a study by Ahmed Alizadah in 2018 brought to focus very significantly that serum biomarkers stayed within a normal range, even in presence of moderate to severe hepatic steatosis, and B-mood scans had very little to add to it, to all this information, except mild to moderate hepatomegaly. Out of all these biomarkers that have been listed here, like ALT, AST, gamma-GT, alkaline phosphatase, and what have you, APRI, which is also called as alkaline aminotransferase platelet ratio index, does show some value, but it still remains inferior to the liver biopsy or elastography in early prognostication of fibrosis. The gold standard in the diagnosis or staging of liver fibrosis from the times immemorial has been liver biopsy. However, liver biopsy, and more recently even the ultrasound-guided liver biopsies, can evaluate only about 1/50,000th of the liver, and of course must have a minimum of 9 border trials that should be seen on HPE. It is invasive, has a complication rate of, even though small, of significant bleeding or severe pain, and is subject to intra and inter-observer variability, not only in histopathological examination results, but also in tissue sampling, since we all know that fibrosis in liver is unevenly distributed. There is, of course, a cost involved, and a bigger, of course, of low patient acceptance of the procedure. Most importantly, due to the impracticality of long-term monitoring through liver biopsies, over the last several years has been going into a growing trend and an urgent need to validate non-invasive tools to diagnose and stage liver fibrosis. Yet, biopsy remains mandatory in one and only one condition, and that is when NASH is suspected. Ultrasound assessment of steatosis, which is the first step in diagnosis of FLD, or we call as fatty liver disease, whether NAFLD or non-alcoholic fatty liver disease, ALD or alcoholic liver disease, and NASH, popularly called as non-alcoholic steatotic hepatitis, is subjective, as there is no standard measure of echogenicity. However, on grayscale imaging of liver, some sort of consensus had to be arrived at by way of grading, albeit a qualitative one, in order to give credibility to the presence of fatty liver. Grade 1 or mild steatosis was when the liver showed bright homogeneously raised parenchymal echoes with round, smooth surface and contours, or attenuation of the intraparenchymal vessels classically gives characterless appearance to the liver due to increased interfaces created by fat droplets that accumulate in hepatocytes. As there is more fat deposition, there is a progressive decrease in the ability of ultrasound to see deeper structures, such as the portal vein, and which results into grade 2 or moderate fatty liver disease, where there is an obscuration of the portal vein walls. Furthermore, if you are unable to visualize the right dome of diaphragm, as you can see here, as compared to the normal liver, if you're unable to visualize and you keep getting this feeling that, you know what, I can't see what's behind it, then we give it a grade 3 fatty liver. All the biometric values, such as those of portal vein diameters, hepatic veins, infamous entry vein, hepatic artery, splenic vein, along with the Doppler studies or prognostication, hugely assist in raising the diagnostic confidence, which we will be discussing later with Dr. Gokhale in his presentation. Suffice to say that liver elastography can include following contributing indications or indicators, such as grayscale imaging and all these parameters, or a more robust reporting protocol. Since fibrosis eventually leads to loss of elasticity, researchers introduced the world to what we call today as shear wave elastography through ultrasound. Now, magnetic resonance elastography, popularly called MRE, even though is promising, but has certain disadvantages. Aside from the significant cost of this study, and of course, the longer period of investigation, not to be able to perform in increased iron load because there is signal to noise limitation, and is subjected to respiratory artifacts. Transient elastography has been validated in multiple studies over a period of time, but shear wave elastography, which we are going to discuss today, and more importantly, the two-dimensional shear wave elastography may be preferred because unlike transient elastography, which consists of a mechanical vibrator which has a high maintenance, maybe every 6 months for right kind of results, and the images that are only created in one dimension, the latter, that is the 2D shear wave elastography, can perform the conventional ultrasound at the same time, give more information, and T also has less sensitivity in presence of obesity and ascites. So to touch upon the basic physics of shear wave, technique called ARFI, an acronym for acoustic radiation force impulse, is utilized. Shear waves are generated using the acoustic radiation force from the focused ultrasound beam. Ultrasound machine then monitors the shear wave's perpendicular propagation through the tissues using a Doppler-like technique and measures the tissue displacement transversely, helping establish the velocity in meters per second. Then, through calculations, this velocity is converted into the elasticity measure, that is Young's modulus given in kPa, taking density of the liver at 1 gram per ml. It is significantly addressed here that for uniformity in reporting between different ultrasound units and operators, shear wave should have a standardized reference in meters per second rather than only in Young's modulus kPa. D has incorporated shear wave as two-dimensional functions versus point wave shear wave elastography, another of the functionality. And these are the basic differences between the two techniques. In point wave, you have 10 breath holds, whereas in 2D, there is 1 breath hold. In point shear wave, we have 10 sample regions, where in this one, we have 1 sample region, 1 reading for each sample, but 10 readings within each with a fast frame rate. So what are the indicators for 2D shear wave elastography? Training of the patients for non-alcoholic fatty liver disease, the first step. Most importantly, early detection and fibrosis staging in chronic liver disease to differentiate between compensated advanced chronic liver disease and decompensated cirrhosis in presence of cirrhosis. To establish a priority for therapy, follow-up of previously diagnosed fibrosis, assessment of patients with known cirrhosis for clinically significant portal hypertension, evaluation of patients with unexplained portal hypertension, and last but not the least, follow-ups to assess response of treatment. To draw your attention to some of the important terminologies that we will be going through in this presentation, in this image, as you can see, this is the skin surface where the probe is placed closely, liver capsule, an echogenic reflector. And then this yellow line that you can see, this is the trapezoidal box, also called as the elastogram box or the Q box, or excuse me, or the region of interest box or ROI. Within this, there is a color-coded stiffness map, which is colored, as you can see, and the sample points in circles with annotations of 1, 2, 3, 4, 5, 6, so that you can exactly know how many samples you've already taken. The edge artifact, these are the edges of the color map, and these edge artifacts, seen here as red, should not be misconstrued as having fibrosis. This is an edge artifact which we need to steer clear of. Through the reference elastogram, elastobar, we can see here that the fibrosis is in red and the softer is the blue. This is, of course, the post-acquisition calculation tool, which includes the ability to analyze all the values for correct interpretation of the results. The results of 10 samples can be stored and displayed as individual results, as you can see here, and a running average from all the ROIs or the region of interest boxes are displayed alongside. So for every color pixel displayed within the box, each has a discrete confidence value ranging from 0 to 48 plus kPa, which can be evaluated pixel by pixel. But in the interest of ease of time, a small circle such as this within the box is put as a small sample average, Corresponding colors then, of course, are red, blue and green, as they are assigned for each pixel in the elastobar that you can see here. And for each patient, it is advised that 2-3 ROIs, that means such Q boxes, should be acquired in segment 8 for a robust evaluation of the liver stiffness, somehow like replicating the biopsy sampling. Measurements of liver stiffness, or as popularly called as LS, using 2D, two-dimensional shear wave elastography, are usually performed through the right intercostal scans, with patient ideally in a left semilateral or supine. Convex multi-frequency probe, which is placed in the anterior axillary line in the 7th to 9th intercostal space, as shown in the image here. Because the sonographic window gets clearer if the intercostal spaces are wide, right arm is placed in the maximal abduction. Deep inspiration is avoided as it increases the measured liver stiffness value. A short breath hold of about 4 to 5 seconds is advised to avoid breathing motion artifacts. Then shortwave elastography is initiated by placing this trapezoid color box, or the Q box, in the most optimal liver parenchymal window, and we acquire the elasticity signals. The ROI box are placed in very homogeneous areas or regions where you see no vessels or the hepatic nodules, to avoid reverberation of artifacts. Hence, the Q box should be placed preferably at a depth which is less than 6 cm liver capsule. When the elastogram signals in this color box map are judged to reach a plateau, the screen is frozen. And a callback of the scans is done, and the most homogeneous is then identified. 10 to 12 samples are positioned in the color box with central distribution, steering clear of the edges so that artifacts are not raised. The sample can be as large as you want. It could be the size has to be reduced in kilopascals and recorded on the image itself. Despite all the goodness of shear wave elastography, there are some pitfalls. Acute hepatitis can have false positives. In patients with high body mass index, which is specifically if the subcutaneous tissue thickness on the chest wall is greater than 25 millimeters, erroneous values may be obtained. Confounding factors such as edema and congestion falsely increase liver stiffness, independent of the presence of fibrosis, since you all know that liver is encased in a distensible yet non-elastic stiff glissons capsule, and this can cause significant variability, which may necessitate a review scan under optimal conditions. Postprandial status raises stiffness by virtue of increased blood flow. Interfering vessels or bile ducts within the liver parenchyma are a big no-no. Less than 1.5 centimeters from the liver capsule or too deep an evaluation, rib shadows and narrow intercostal spaces, edge of Q box at an angle to the capsule while scanning, increased pressure while scanning, all can increase the liver stiffness falsely. So when we are talking of downsides of elastography, in order to minimize this downside, leading to variability in obtaining accurate results, a statistical analytical model called Interquartile Range has been incorporated in the ultrasound machines in post-acquisition tools. Now, IQR, or Interquartile Range, is a descriptive statistics. It is also referred to as the mid-spread or middle 50%, or typically the 8th spread. And it's a measure of standard dispersion being equal to the difference between the 75th percentile and the 25th percentile. The highest and the lowest values which interfere with the accuracy of interpretation. A more sensitive parameter by median ratio has also been incorporated in EEG machines, and a value of less than 30% suggests a robust data set. To summarize best practices, do refer to the median as a safe value and not the mean across the sampling calibers, which eliminates the outliers, and importantly, refer to the IQR median ratio as quality criteria for the measurements in KPA. Confidence values of greater than 60%, measurements must fall in a comparable range value. Apart from this, to recap, 2 to 3 RY samples with 10 samples in segment 8 with optimal probe positioning in suspended respiration and fasting of at least 8 hours. As you can see in this image here, the left lobe of the liver is really not discussed in elastography because it will not be able to support optimal positioning of the elastobox due to the insufficient thickness or depth. Also, the cardiac pulsations that will be coming will interfere with the quality of image. Several factors can lower the confidence value despite a good technique and a color map acquisition. Tissue areas with blood flows, vessels such as this or this, and oops, just missed this one here. Low echogenicity, such as in gallbladder fossa or in presence of scanning at a depth or an angulated Q box of large tissue motions, such as in a restless patient, inability to cardiac, can all compromise the quality of results. We've already spoken about the artifacts and a little more here. Edge artifacts, as you can see here, as you can perceive here, and need a repositioning of the probe. The best way to avoid, and in addition, the quantitative sampling, what we call as the samples, should be performed centrally, steering completely clear of the edges. This is a reference chart from GE Healthcare documents for your take-home reference, automatically related by the ultrasound software, used to establish the elastography grades based on the most reproducible system called net grade system, as you can see here, F1, F2, F3, F4. The list present a continuous range of values with some overlaps and correlates for 8 kPa is understood to be a range not incorporated here or a normal scan. Now the cap values here also called as controlled attenuated parameters. I have included here in this chart because my referring physicians were more tuned to knowing what the cap values are and are more comfortable knowing what the range is. So a quick recap and a follow through. We have normal to mild, that is F1, and ranges of the elasticity KPA, which you can always correlate and open for your reference. Mild to moderate is F2, moderate to severe is F3, and cirrhosis is F4, where 1.31, and the shear wave velocity greater than 1.76 meters per second. And steps of scanning. Node segments 5, 7, or 8 can be chosen, any one of them, and diagnosed as this patient was diagnosed as NAFL, and he showed a Medicare score of F0 since the median of the Young's modulus was 4.64 kPa. The shear wave velocity was less than 1.47, and the entire pattern of the IQR median was 9.5%. Quite a robust data this was. Portal vein, splenic vein, splenic size, their Doppler velocities raised the degree of confidence. There was a bit of splenomegaly on the outer side. However, there is splenic elastography now, which has been a recent add-on. And on shear wave elastography, the KPA of 9.1 was obtained here. It is considered that if it stays less than 16 kPa, that's within normal limits. And this was provided by Abdominal Radiology New York study. Any greater value than 16 kPa is reflective of evolving hypertension interpreted in conjunction with the liver stiffness staging. This was F1 stage in a patient with mild to moderate fibrosis. The elastobox is showing hues of green corresponding to the median Young's modulus of about 6.43 kPa and the shear wave velocity ranging between 1.47 and 1.48 meters per second. IQR median ratio corresponded to about 30.5, which is indicative of pre-data and not a significant variability. IQR median in this patient stood at 24.2, a median KPA of 6.85, and a velocity of 1.48 to 1.64 range was seen, and this was highly indicative of significant fibrosis and F2 grading. The patient was uncooperative, and we had a few edge artifacts, as you can see here. However, a robust data was obtained by steering clear of the edges and taking the samples in the central zone. Portal vein caliber was normal, and so were the Doppler studies, and the flow was hepatopetal. In this yet another asymptomatic obese patient having type 2 diabetes and grade 3 NAFLD. Elastography showed a liver stiffness which was falling in the range of 8.3 kPa and velocity ranges between 1.64 to 1.76 meters per second, indicative of severe fibrosis and F3 of Metveer stages. Centrally placed red color signals were not artifactual. IQR mean ratio stood at about 28%, which was robust. Here we reiterate a physics principle, that is, as the fibrosis increases, the velocity propagation also increases in the tissue. Spleen size was borderline enlarged, and a kPa of about 10.6 was there, eliminating presence of varices or clinically significant portal hypertension for now. However, this indeed fell in the range of compensated advanced chronic liver disease and was kept under a follow-up observation. This was a lady with uncontrolled diabetes and dyslipidemic status with borderline deranged serum biomarkers. Severe fibrosis, and all values were falling in the range of cirrhosis, such as that median of 10.44 kPa and shear wave velocities which were greater than 1.7 meters per second, and an F4 stage was given to this patient. Data acquired was high quality with an IQR median of 15.1%. Additionally, there was attenuation of hepatic veins which was noted. Following the case examples, it must be quite clear to you also that just knowing the presence of fibrosis or having a compromised values in serum biomarkers is just one of the things and feels kind of as an insufficient information. Hence, staging of the disease to glimpse into the future of the patient, to see how the disease is going to evolve, what will be the complications, and when are they going to occur is the big step towards what the clinician actually wants to achieve. In 2015, Babino 6 consensus defined a new term called as compensated advanced chronic liver disease in order to better define, better understand the spectrum of advanced fibrosis and cirrhosis in asymptomatic patients. Staging the chronic liver disease, most importantly the prognostications, is of early fibrosis, which is because reversible we must know as early as we can. Compensated advanced chronic liver disease, salvageable, cirrhosis, and then prognosticating the complications of cirrhosis, such as portal hypertension, falling into the category of clinically significant portal hypertension, presence of esophageal varices, risk of bleeding, and hepatocellular carcinoma. To summarize all this jargon, we must understand a basic principle, and that is greater than F2 equal to greater than F2 stage of Metveer is significant fibrosis, and F4 is cirrhosis with accompanying complications. In between the two lie compensated advanced chronic liver disease, which we can confidently rule in, that is confirm, or rule out and keep the patient under follow-up treatment through cutoffs of kPa as well as shear wave elastography on 2D shear wave elastography. So to recap, F2, we all know, is significant fibrosis within a particular range. However, we can rule out significant fibrosis if the elasticity measure is less than 5.5 kPa. If the kPa is greater than 6.78, we can confidently rule in significant fibrosis. Similarly, we know F4 is cirrhosis. We wish to know whether it is bordering compensated advanced chronic liver disease or is suspect advanced chronic liver disease, and for this there is a value ruled out if it is less than 8.41 kPa. Then we say not compensated advanced chronic liver disease, and if this elasticity measure is greater than 9.15 kPa on shear wave elastography, this is a rule in cutoff. That means we are having a suspect chronic advanced chronic liver disease. If this patient is asymptomatic, we can have additional supporting investigation and keep this patient under very regular. Greater than 13 kPa is positively ruling in of advanced chronic. Armed with this understanding, non-invasive shear wave elastography technique can help avoid unnecessary biopsies and an assessment of portal hypertension with kPa greater than 17, suspect esophageal varices or varices needing treatment called VNT, which is a relevant step if it's greater than 20 kPa. But this is along with the liver stiffness measurement and splenic stiffness or splenic stiffness of greater than 16 kPa. And this is really the most important relevant step in the evaluation of newly diagnosed advanced chronic liver disease. Here is another easier way of understanding the rule-in concept if you found the earlier one a little complex. And this is a graphic representation of shear wave velocities of liver stiffness measurements for meta-wave stages and the consolidated information that I have gathered for you, which was a recommendation of the consensus panel from SRU, which is the Society for Radiologists and Ultrasounds. Now, this is to interpret results by using only two cutoffs. One, to select patients that are at low risk of clinically significant fibrosis, like in F0, F1, velocities lesser than 1.3 meters per second, who would not need additional follow-up. And another is the cutoff to select patients at high risk for advanced fibrosis or cirrhosis, like F4, velocities greater than 2.1 centimeters, as you can see here in the graph, who require different management and prioritization for therapy. Now, between these two cutoffs, there is a substantial overlap of fibrosis, which is of stages F2, F3, and here the rule of 5 or likelihood ratios will be better tools for documenting risk and stratification. This was a patient posted for cholecystectomy, post-CVD stent for choledocholitis for a pre-op assessment scan. On grayscale imaging, coarse echogenic liver and splenomegaly was noted. Shear wave elastography for clinical interest were performed, and we found a kPa that was showing a median of 8.8 in the F3 range of Metavirus score. That of the spleen was 9.6, definitely less than 16 kPa for any significant value. A diagnosis of compensated advanced chronic liver disease was given. So patients with compensated advanced chronic liver disease should be evaluated for the presence of clinically significant portal hypertension and must undergo regular surveillance for hepatocellular carcinomas, esophageal varices, and varices needing treatment. Here's another case, and I'm just going to stop this for a while. In yet another case, here was a healthy patient, a young man with upper abdominal pain, was having acute portal vein thrombosis with suspect underlying chronic liver disease. As you can see, the liver granular and showing high echogenicity. So immediately a transjugular portosystemic shunt was put between hepatic vein and the right branch of the portal vein. On his second visit, liver elastography showed a kPa which was almost 10, and the IQRM ratio, of course, was 17.6, so the data was quite good, and the splenic kPa was bordering 15.2, though no portosystemic collaterals were seen at the splenic hilum, as you can see in this video here. A diagnosis of clinically significant portal hypertension with a high probability of varices was given, and this patient was later on shifted to a higher center. So this is my last of the slides, and here is what we advocate for a reporting standardization. One must always provide a median value in kPa and velocity, the shear wave velocities in meters per second on net wave scoring or staging. An IQR median ratio should be given as quality of good data. Each inference must indicate whether the patient is at minimal risk, that is, of having clinically significant fibrosis or not, and stage F0 or F1. No follow or maybe a follow of 1 to 3 years is noted. This can be done at a moderate risk of having clinically significant fibrosis, such as that in stage F2 or F3, so that additional appropriate testing and a follow-up 6 monthly or compensated advanced chronic liver disease can be, or at high risk of having clinically significant fibrosis, that is stage F4 and sometimes an overlap of F3, so that a follow-up can be advised 3 monthly with risk stratification or clinically significant portal hypertension, esophageal varices needing treatment, but not the least, and very importantly, the patient position when the shear wave elastography is performed, the equipment that was used, machine manufacturer, and the transducer frequency must be put down in all the reporting formats for uniformity in interval reporting should the patient not come to you and reach some other center. I thank you for your great patient hearing. Thanks very much. Over to you, Zenith and Dr. Gokhale.
Thank you, Dr. Bhatnagar, for your informative talk and explaining the role of shear wave elastography in staging the liver diseases and sharing the tips and tricks in that. Now I would like to welcome Dr. Sudheer Gokhale, and so over to you, sir.
Thank you, Zenith, and thank you, Team GE, for doing this webinar on and color Doppler in portal hypertension. I'll talk about color Doppler in portal hypertension in the next 30 minutes or so. Now, portal hypertension is defined as the definitive diagnosis, of course, is increased wedge hepatic venous pressure gradient of more than 10 millimeters of mercury. But that needs invasive procedure, and therefore when we are doing non-invasive testing, we rely on ultrasound and color Doppler to diagnose portal hypertension. And that we do by looking at several things, but basically it comes to looking for presence of varices, and clinically, of course, variceal hemorrhage or presence of ascites is also one of the diagnostic criteria decided by the Bovino 6 consensus workshop to say that there is clinically significant portal hypertension. Now, how do we go about looking at portal hypertension? We know that it is of 3 types depending on the cause. It could be pre-sinusoidal. So pre-sinusoidal portal hypertension causes are either extrahepatic like portal vein occlusions, or there might be a arteriovenous fistula in the portal system increasing the pressures, or there can be intrahepatic lesions like congenital hepatic fibrosis, biliary cirrhosis, idiopathic non. Or it could be sinusoidal, that's the commonest cause of cirrhosis. Or some rarely we might have post-sinusoidal, which is beyond the sinusoids, the obstruction beyond obstruction in the outflow of the liver, like Budd-Chiari syndrome. Any of the hepatic veno-occlusive disease will result secondary portal hypertension because of the flow. So when on ultrasound, we simply define them as pre-hepatic, hepatic, and post-hepatic, depending on the cause. So hepatic, of course, are the commonest causes. We know that because the cirrhosis is, of course, the commonest of all the causes of portal hypertension. Pre-hepatic causes in the Western literature, they are mentioned about 9% incidence, but in our country we find about 20 to 30% of established clinically significant portal hypertension is because of pre-hepatic portal venous occlusion. And a lot of them are infections or inflammations that have resulted in the childhood, and that has resulted into portal thrombosis and obstruction. And then later on, it might present as portal hypertension. A lot of times it is a chance finding, a surprise finding on ultrasound. Post-hepatic causes are, of course, rare, as we already said, the hepatic veno-occlusive disease or the Budd-Chiari syndrome. Now, portal hypertension is responsible for most of the complications associated with cirrhosis. specifically variceal hemorrhage, ascites, and hepatic encephalopathy. We need to differentiate between, we need to understand the concept of portal hypertension disease versus portal hypertension. Why? Because as radiologists, we often see patients who have had portal hypertension for quite some time, but don't actually have high portal pressures when they present to us in our departments. Why? Because they have already bled massively and the portal system is already decongested. So there might not be actually high portal pressures when we see the patients. And therefore we need to understand this concept of portal hypertension disease versus actual portal hypertension at the time of examination. Now let us recall the anatomy just a little bit. We know that the portal vein is formed by confluence of the splenic and the superior mesenteric vein just at the level of the head of the pancreas, and then it runs into the free edge of the lesser omentum towards the hepatic hilum where it bifurcates. Remember that normal portal vein always bifurcates. There are no 3-4 branches. So if you see 3-4 branches, that's not a normal portal vein bifurcation. And there are certain other veins which will act as collateral veins later on if there is a high pressure in the portal system. So we need to remember their anatomy as well. We have the left gastric vein running from the portal vein along the lesser curvature of the stomach. We have the Lino renal veins going from the splenic hilum to the left renal vein. We have the gastrosplenics, the short gastric or the gastroepiploics, and we have the pancreatoduodenal veins around the head of pancreas and into the mesenteric root. Now, the hemodynamics of portal hypertension. The portal pressure builds up in response to fibrosis. Fibrosis doesn't allow blood to flow forward through the liver, so the pressures build up. Visceral congestion causes a large percentage of blood to be pooled in the portal system. We know when a stream is dammed up, water accumulates until either the dam overflows or the stream founds ways, the water founds ways around that blockage. So that's exactly what is happening in the portal system. If there is a blockage to the forward flow of blood into the portal vein, the pressures build up and blood will try to find other ways to bypass this occlusion and to flow again back to the heart. Portal hypertension, as the pressures build up, this pressure itself drives some flow towards the liver, but that will be at the expense of a pressure gradient, and this pressure gradient will open up the collaterals. The collaterals will start flowing in reverse direction as against their normal direction. In initial stages, there is an increased blood flow. This increase is established through splanchnic arteriolar vasodilatation caused by an excessive release of endogenous dilators. The increased flow contributes to the ability of portal hypertension to exist despite the formation of an extensive network of portosystemic collaterals that may divert as much as 80% of the blood flow. So how do we go about diagnosing portal hypertension? We will look for evidence of increased portal vein pressure by analysis of portal venous flow pattern, and we will look for the chronic effects of portal hypertension in the form of dilated portosystemic collateral channels. But first, we will always begin with a grayscale sonography. We'll look at the liver because, as I said, in 80 to 90% of cases of portal hypertension, that will be the cause. So we'll look at the liver size and ecostructure. Then we'll look at the portal vein and other splanchnic veins. So we'll look at their caliber, whether they are dilated, and we'll look for respiratory variations. When the liver is soft, it varies in volume with respiration. It gets compressed as the patient takes a breath. The liver gets compressed by the movement of the diaphragm. And this malleable liver, as it gets compressed, it does not allow a good forward flow through the portal vein, and that produces the respiratory variations in the flow of the portal vein and in the caliber of the portal vein itself. And we will look for any visible collaterals on 2D examination as well, and also we'll look for the splenic size, which will reflect the congestion in the splenic in the splanchnic vascular bed. The first sign may be a change in the liver shape. As the liver contracts, for some reason the right lobe contracts more than the left lobe. So the relationship changes. There is a difference in the right-left lobe ratio, and the left lobe appears relatively large as compared to the right lobe, which contracts more than the left lobe. Then there will be fine changes in the echo texture as the fibrosis increases. Of course, we'll know much earlier on elastography, as Nidhi has already explained this in detail. But if you don't have recourse to the elastography, advanced changes of fibrosis will be visible as coarse echo texture and as very fine irregularity on the surface of the liver. As the fibrosis advances, it will produce nodularity. So once it's fairly advanced, this liver surface really becomes extremely nodular, and that is visible on 2D ultrasound very easily. Then we'll look at the portal vein caliber itself. The normal portal vein caliber is less than 10 millimeters. There are certain studies which have put the caliber cutoffs at 13 millimeters and some at extreme at 16 millimeters. But I usually use 10 to 12 millimeters as the upper limit for portal vein normal caliber. And the normal portal vein caliber will vary with respiration. So as the patient takes a deep breath, the portal vein caliber will increase. And this increase should be more than 20% of the lesser caliber. So that we'll also look at the portal vein caliber, whether it changes. If there is portal hypertension, the caliber will not change. It will remain exactly the same. Only thing is you have to be careful that you measure the caliber exactly at the same point. So that point of reference can be where the hepatic artery crosses the portal vein or some other landmark that you can obviously see, and you measure the portal vein caliber exactly at the same place in deep inspiration and deep expiration. And then we'll look for visible collaterals. If there are large collaterals, they will be obvious on your 2D ultrasound examination. They will stand out. But as I said, very often we don't see visible collaterals on 2D ultrasound examination because the patient has bled massively and all the collaterals are collapsed, and therefore they might not be visible on our 2D scan. And then only we'll proceed to the Doppler assessment of portal circulation. So when we do Doppler, we'll look at the flow in the portal vein, whether there is or there is no flow, which is the direction of flow, whether the respiratory variations are seen in the flow, and sometimes we might do some quantitative assessment of the flow. And then we'll look for the collaterals on color Doppler, and we'll try to do some mapping of the collaterals, which are the areas affected, where are the major collaterals, what is their flow, and which part of the circulation these collaterals are flowing towards, whether they are flowing towards the superior vena cava or they are flowing towards the inferior vena cava, and that has some relevance. I'll talk about it when I come. So on color Doppler, we'll see that the portal vein it shows a good wall-to-wall filling. There are no filling defects. We know that there are no walls in the portal vein, so we'll not see any. The caliber of the portal vein, as I said, is about 12 millimeters. If it is more than that, we'll say that it is a slightly large portal vein, larger in caliber, and it will show a hepatopetal flow towards the liver. Always, if you are looking from the liver side, it will appear in red. If you are looking from the pancreas side, it will appear in blue. So always remember to look at your color bar chart, because the flow in portal vein can be in different directions. So you need to make sure which way the blood is flowing in portal vein. And if you do a spectral waveform, you will find that as the patient breathes, the waveform will show change in the flow velocities, and that is a normal respiratory variation in the portal venous flow. So flow velocities are usually 15 to 18 centimeters per second, usually less than 20 centimeters per second, and the respiratory variations between the inspiration and expiration should be about 20%. So the velocity change should occur more than 20%, and that's a normal variation. At the same time, we'll also sample the flow in the hepatic veins. The hepatic veins, we know that all of them will flow towards the inferior vena cava. And if we happen to sample flow into the hepatic veins, that will typically show a pulsatile flow, because hepatic veins are reflecting changes in the right atrial pressures. And therefore, it typically has a M-shaped configuration, or at least it will be a significantly pulsatile flow always in the hepatic veins. Now, when there is portal hypertension, the portal vein caliber increases and the portal venous flow reduces. So the flow velocities will reduce. They will be less than 20 centimeters per second. And if there is a significant hypertension, the respiratory variations will be lost, and we'll just see a flat waveform to the portal venous flow when we check it on the spectral waveform. Now remember that low flow velocity, when you measure it on the pulse wave Doppler, is a specific sign, but it is not very sensitive. So in a lot of patients with established portal hypertension, the flow velocities might still be a little higher than our cutoffs of 20 centimeters. So that's not a very sensitive sign that you need to remember. So here again, another patient who is obviously cirrhotic, there is ascites, the portal vein is large in caliber, but the portal flow velocities are not very low, so it varies from 27 centimeters to 20 centimeters. But once the cirrhosis is advanced, once the portal hypertension is significant, we'll always find low flow velocities and a very flat waveform in the portal vein, and also loss of pulsatility in the hepatic venous flow, as well as the liver becomes stiffer and stiffer. It does not allow the hepatic vein pulsatility to happen. Now remember that when you are looking for respiratory variations, you have to be very careful, because as the patient breathes, your sample volume moves within the portal vein. So it can move from one end of the portal vein to the other end of the portal vein, and that will make the Doppler angle change, and that can bring in a falsely changing flow waveform. So a false respiratory variation might be seen if the patient's respiratory excursion is significant and your Doppler sample moves within the portal vein, and that changes the Doppler angle. Remember that when we are doing spectral waveforms and measuring velocities, they are totally angle dependent. So if the angle changes, the measurement will also change. So you have to be a little careful. Another thing you have to be a little careful is that sometimes paradoxically you might see high flow velocities in established cirrhosis and portal hypertension, and there are reasons for that. If there are collaterals beyond the liver which are siphoning off blood from the liver, so there is a way for blood to flow out of the liver apart from the hepatic veins and IVC, then the forward flow in the portal vein is maintained, and therefore you might see a good amount of flow velocities within the portal vein, even though there is a established clinically significant portal hypertension. So that you need to remember. As the pressure increases further, portal flow becomes biphasic and may ultimately reverse. It might start flowing in the reverse direction. So in initial stages, you might see that the splenic vein and the portal vein, they flow sometimes towards the liver, and sometimes they start flowing in the reverse direction. So initially it might be that there is an intermittent reversal, but eventually there may be a constant permanent reverse flow into the portal vein and splenic vein that might happen depending on where the collaterals have opened. So remember, whenever we see a reverse flow in the portal vein, that is a very significant marker that there is a significant portal hypertension, usually probably because of cirrhosis, but that might happen in Budd-Chiari syndrome. That might happen if the patient has had a TIPS shunt and that has got blocked, or if there is a intrahepatic arterioportal fistula and that is creating a very high pressure in the portal. Therefore the portal vein starts backward. As the cirrhosis gets established and the portal venous flow starts reducing, Nidhi has already talked about it, we start seeing higher and higher flow through the hepatic artery. The hepatic artery tries to compensate flow which has been lost from the portal vein, and therefore we start seeing a lower resistance pattern into the hepatic artery. So we might check the hepatic artery flow, and if we have the hepatic artery RI below 0.7, we know that this is a low resistance flow in the hepatic artery. Previously, we used to do a lot of quantification of the portal flow by using congestion index, portal hypertension index, and portal pressure measurements, etc. But we don't do that anymore. And then next thing that what we'll do is to map the collaterals. We'll check where are the collaterals in which geographical area and try to establish a pattern. So we'll look at different types of collaterals. There are some collaterals which are portohepatic collaterals with flow towards the liver. So they are periportal collaterals, mainly because the portal vein is lost. There is no portal vein is occluded long back, and there is a leash of periportal collaterals like a bunch of veins which we call portal cavernoma. The portal vein is not seen, and we see a leash of several tortuous collateral veins flowing towards the liver. They are periportal collaterals, and often in these patients we see a lot of collaterals in the gallbladder fossa as well. This can happen later also. Usually it happens as a childhood inflammation, obliteration of the portal vein, and they later present as portal cavernoma. But in later stages, in cirrhosis also, you might get portal vein occlusions, portal vein thrombosis, and which might develop periportal collaterals. Sometimes these periportal collaterals there might not be very many periportal collaterals. There are only 2-3 periportal collaterals. Like this patient was sent to me for a second opinion, in which there was portal hypertension. You can see a flat waveform, but it was thought that the portal vein was patent. But when you look at this portal vein, it does not bifurcate. It divides into 4 or 5 branches. We know that a normal portal vein cannot divide into 4 or 5 branches. So normal portal vein is gone. This is not a normal portal vein. These are all periportal collaterals, so that you need to keep in mind. Extrahepatic portal vein occlusion can happen secondary to some inflammatory or neoplastic process involving the portal vein, but that is very, very rare. Then the next important collateral is the left gastric or the coronary vein, which runs from the portal vein towards the left side of the stomach, along the lesser curvature towards the esophagogastric junction. And this could be a thick tortuous vein in the epigastrium. So we can see it often in our 2D scans also. And we'll make sure on color Doppler whether the flow in this left gastric or the coronary vein is away from the portal vein. That tells us that this is a significant collateral flow away from the portal vein. And measuring the left gastric or coronary vein is important, because we know that when it is larger than 5 millimeters, larger than 7 millimeters, it is highly likely that this patient will have variceal bleeding, because this is a main supplier to the esophageal and gastroesophageal varices. So we need to measure the left gastric or the coronary vein. And how to look for that is you need to trace above, superior to the portal vein, and you will see this vein run parallel and obliquely to the splenic vein, not parallel but obliquely to the splenic vein, going towards the esophagogastric junction in the epigastrium. And we make sure that it is flowing away from the portal vein because it is a collateral. We might see short gastric collaterals along the wall of the stomach. So if you look around the wall of the stomach, you will see these short gastric collaterals, and we know that these are also significantly dangerous collaterals, because these patients can also have massive hemorrhages because they open directly into the stomach. So on real time, we can see these collaterals running off from the portal vein towards the stomach. And in the gastric bed, we see all these big collaterals going towards the stomach. Then we can have gastrosplenic collaterals, and the best way to look for them is through the spleen from the left side. And we will see these collateral veins from the splenic hilum running superiorly towards the esophagogastric junction. Here we have another on real time. We have large big veins running from the splenic hilum. So we have a reverse flow in the splenic vein, and that flow runs off in these collaterals running towards the esophagogastric junction along the medial border of the spleen. Of course, these are better seen on CT, because we don't see the perigastric and the periesophageal complexes very easily on. Then we have the fourth type, the Lino-renal collaterals, which we all again see along the left renal hilum and running from the splenic hilum to the left renal hilum. So here we have these veins running from the splenic hilum, going inferiorly to the renal hilum and joining the left renal vein. In all these cases, we will find that the left renal vein is large in caliber, and it shows a very high flow because a lot of blood is coming back from the splenic vein and joining the left renal vein. Here again, the same thing on CT. Then we have another important group of collaterals which run along the dorsum of the spleen. So they run from there is a reverse flow in the splenic vein, and then we have these bunch of collaterals running along the border of the spleen, along the inferior edge of the spleen, and going over to the dorsal surface of the spleen to go to anastomose with the lumbar and intercostal veins. So all these veins will eventually drain into the inferior vena cava. And then we can have very irregular tortuous collaterals joining the pancreatoduodenal or mesenteric veins or the iliac veins as well. And then one collateral vein through the liver, which is a recanalization of the umbilical vein. So it is a very superficial vein, and very often if you are pressing with your convex probe, it gets obliterated. So you need to remember that they are very superficial veins running off the liver and into the abdominal wall. So you need to go light on your probe to look at them, or sometimes you might use your linear probes to look at the abdominal wall and see this umbilical vein draining into venous plexus. And in all these patients, you will always see that the portal venous flow is not decreased. Although the respiratory variations are gone, but the velocities are still very, very high, because as I said, these veins are decompressing the liver. They are taking blood. The blood is running off the liver, and therefore the portal venous flow towards liver is fairly well maintained. And then rarely you might have intrahepatic portosystemic shunts. So you'll see these irregular veins joining the portal vein to the capsular, subcapsular veins or the hepatic veins, and they are also joining the portal vein to the systemic circulation. And then in some patients with Budd-Chiari syndrome, we might get secondary portal hypertension. Typically, you don't see the hepatic vein. The hepatic veins will always stand out even on your 2D ultrasound scan. We are very familiar with that trident appearance of the three hepatic veins that we see on our big transverse axial scan. So once they are obliterated, we don't see them. If we do color Doppler, we'll find intrahepatic collateral veins running off the unobliterated part of hepatic vein into other collateral veins, which will actually drain into the subcapsular vein. And in these situations, the normal pulsatile flow waveform of the hepatic veins, and we'll see a continuous waveform in the hepatic vein. Sometimes the hepatic veins are patent, but the problem is in the terminal IVC. So either there is a terminal IVC stenosis, or there may be a web in the terminal IVC, and that will be seen as a high velocity turbulent flow in the terminal IVC. The hepatic veins are patent, although their pulsatility will be lost because of the distal stenosis. Another patient here with a long segment stenosis of the intrahepatic part of the IVC, which shows a very high velocity turbulent flow through that, and that's the cause of secondary portal hypertension. Some of these Budd-Chiari patients will have a lot of intrahepatic collaterals. So we see a jumble of web-like structure within the liver, and on color Doppler we find that they're all intrahepatic collaterals, and that is what is seen as a honeycomb pattern if we do a venogram in these patients. So the purpose of mapping of these collaterals in my mind is to help us decision making for treatment. So what we need to do is to figure out which way these collaterals are flowing, whether these collaterals are flowing towards the inferior vena cava. They are safe collaterals, like the periportal collaterals, like the umbilical vein, umbilical plexus, like the Lino renal collaterals or paraduodenal, pancreaticoduodenal collaterals. All these collaterals are taking blood away from the portal vein towards the inferior vena cava, and therefore they are safe collaterals, except for the hemorrhoids, of course. But if there are prominent collaterals which are taking blood towards the superior vena cava, like the coronary vein, like the short gastric veins, the gastroepiploic veins, the gastrosplenic collaterals, all these collaterals are taking blood towards the superior vena cava, and doing that, they will flow blood through the paraesophageal complex, and that will cause severe massive bleeding. No matter how many times you do endoscopic variceal ligations, these patients will keep coming back with bleeding, and therefore they will need a definitive treatment. So we use all this information as aid in planning we used to do it for surgery. Now we decide whether this patient needs a shunt, an intrahepatic shunt, or he can still do well with a conservative treatment by variceal ligation. These are different types of shunts. We don't do them anymore, but sometimes you might come across patients who have had shunts in the past. So that's how a portacaval shunt looks like. So we have a direct communication between the portal vein and the inferior vena cava, and that shows a very high velocity, turbulent, sometimes bidirectional flow on pulsed wave Doppler. The most common and most popular shunt, which is still sometimes done in some patients, is a Lino renal shunt, where the splenic vein, the distal splenic vein, is cut and anastomosed to the renal vein. So you have a persistent reverse flow into the splenic vein and then forward flow into the renal vein when this Lino is patent. In children, we used to do a mesenterico-caval shunt. We would cut off the superior mesenteric vein and anastomose it to the IVC. So there will be a reverse flow into the superior mesenteric vein and then forward flow into the IVC. Sometimes in children this is still done, but most of the cases now, the treatment of choice, if a interventional procedure is needed, is a TIPS shunt, where we put a artificial graft shunt between the portal vein and the hepatic vein. So the blood is shunted off the portal circulation into the hepatic veins and eventually to the IVC. It's a good or better than other methods of treatment, significantly improves the quality of life. Technical success rate nowadays is more than 90%, although the survival rates have not improved, but the quality of life has improved. You can see this shunt on 2D because it is brightly echogenic. You will see it placed between the portal vein and the hepatic vein. And that's the normal hemodynamics, when the shunt usually is placed between the right branch of the portal vein and right hepatic vein. So you have a reverse flow into the left branch of the portal vein, but a forward flow into the portal vein. That's the normal circulation that we'll see. And on color Doppler, once the shunts are placed, we can monitor them to see that they are patent and the blood is flowing well through these shunts. Always the blood is flowing well. So on color Doppler, you can see that the shunt, although a little narrow, but still the blood flow is normal, the velocities are normal, and here the caliber is also normal and the blood is flowing fairly well. This stents might stenose, and then it will show us a very high velocity turbulent flow on pulsed wave Doppler. So we can do sampling in the narrowest part of where we see aliasing within the shunt and can check whether the velocities are significantly increased. Typically, the portal vein flow velocities will also reduced. In the left branch of the portal vein, we'll start seeing antigrade flow instead of retrograde flow if the shunt is dysfunctioning. And the velocities will increase typically above 1 meter per second within the shunt. That's diagnosis. Unfortunately, sometimes the shunts might block, and typically we will not see any flow neither on color Doppler or on pulse wave Doppler, and that's really a bad situation for the patient. So I'll sum up by saying that the role of ultrasound and color Doppler in portal hypertension is confirming the diagnosis, mapping of collaterals, assessment of veins for planning treatment. So we'll see typically whether the majority of flow is towards the SVC. These patients will need some sort of shunt because they will keep coming back again and again for variceal ligation. And once the shunt is in place, we'll do monitoring for the shunt patency. Thank you very much.
Yeah. Thank you, Dr. Gokhale. It was a great talk, and you nicely explained the role of color Doppler in portal hypertension. And now we have some questions. Now I would like Dr. Nidhi and you to answer those questions. I just read out. So, first question is how to recognize the multiseptate liver abscess.
Multiseptate liver abscess, is that directed to me or Dr. Gokhale? I think Dr. Gokhale will be taking that question.
Now, it's not really relevant to today's talk, but we'll answer anyway. When you say multiseptate liver abscess, it's actually an abscess in evolution. Now, you know that abscess forms by liquefaction of the liver tissue. So there is a centripetal growth of this liquefaction. So the abscess passes through stages of phlegmon and then liquefaction. So the liquefaction might be more at one place, lesser at other place, and that might create a false appearance of septations. Once a abscess is fully formed, there is no liver tissue in between, or there are no septae developing in between, unless there are 2-3 separate abscesses placed very close to each other, and therefore the intervening tissue might appear as septae, or in the chronic stage, the abscess acquires a pseudo wall, pseudo capsule around it because of the fibrosis. And if there are 2-3 closely placed abscesses, this might appear as septae.
Thank you, Dr. Gokhale. So the next question is how to do elastography.
How to do elastography? Okay, that is a long answer. I think I think I'm going to just share the screen and go back to the place where we were discussing techniques, and just going to share the screen. Yeah. Can you see the screen, Zenith?
Yes.
All right. So this is for you. For your question, how to do elastography. It's quite a simple procedure. It is predominantly a technique which you need to become friendlier with your machine, your unit that you're working on, because every machine has their own processes which you have to activate in order to get the right kind of images. What we do, this is an S8 that I was working on, GE. The patient, of course, is in supine or left lateral decubitus. And the convex probe is placed between 7th and 9th intercostal spaces, depending upon what is the clarity of the window that you're getting. The patient has to hold the breath for a little while. And of course, the arm is abducted so that the intercostal spaces widen up. Once this entire positioning is done, we activate. There is an activation button, elasto, on your machine. You activate that elasto button, and that button gives rise to a cue box or a region of interest box right here. You've already chosen the area of the liver that has the best window. So that's where you position the cue box, keeping so that the surface, the cranial surface, is 1.2 centimeters from the liver capsule, and it does not go beyond 6 centimeters of depth. This color map, this is a color-coded map that comes in that trapezoidal cue box. Once that is activated, you ask the patient to suspend the respiration. That means the patient neither takes a deep breath nor exhales, just suspends the respiration for about 2 to 3 seconds. And once that is done and you activate, go on the activation button, there will be 3 to 4 frames. In fact, in my machine, there are 3 to 4 frames that come per second. So you stop when you find that a plateau of a great homogeneous color map has been raised. You can also scroll back to see what frame you like the best. Once there you do that, the samples are put, and it's again, you have to activate a button for the samples. And 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I used to take about 12 samples that go in the central region of the color map box, steering clear of the edges. And as soon as you do that, you get this reference reporting format on the image itself. Then, of course, as you go for any reporting format within the machine unit, you can go to that post-acquisition tool of the reporting format, and that's how the basic. And of course, the other thing I would definitely like to say is that don't stop just because you've got one good color map. Do put in 2 or 3 more ROIs in different places, steering clear, of course, of the vessels and the nodules if they are present. And then you get the median, and you get your IQR median ratio, which should be less than 30% to give you that your data acquisition was good quality. And that, of course, gives you, then you have to see for that median and compare with the METView chart, which could be incorporated in your machine, or you may have your own reference charts. And that's of the elastography, at least 2D. We are talking of
Thank
2D, two-dimensional shear wave elastography.
Thank you for the elaborative answer. Ma'am, any limitations on assessment of shear wave elastography of patient with abscess and ascites?
Oh, yes. I mean, if you are doing a shear wave elastography and the patient has got liver abscess, we would really not want to do, because it'll give us falsely high results. It creates inflammation or hepatitis, and that would give us raised stiffness. That does not mean exactly that the patient will be having fibrosis, but definitely there will be a raised stiffness and it will be falsely positive. In ascites, is Zenith the next one you said ascites?
Yes.
Ascites, there are no limitations. That's actually one of the advantages over transient elastography, that 2D shear wave elastography or point shear wave elastography can be done wonderfully well without having any limitation in presence of ascites, which the transient elastography does suffer a downside from.
Okay. So next question to you, sir. The question says, I think we have discussed already in the presentation, but there's a question that kindly explain the portal Doppler and portal hypertension abnormality in liver transplant cases.
Here, I presume the person is asking if a patient has had a liver transplant and later develops portal hypertension.
Yeah.
So it could be because of a portal vein thrombosis, or it could be because of a episode that the patient has developed cirrhosis again, which is would be very surprising. But the criteria for diagnosis will remain the same. We'll look at the portal venous flow. The commonest thing, as I said, is portal vein thrombosis. So we'll first need to check whether the portal vein is patent and it is flowing well, or the hepatic veins are patent and they are flowing well, because thrombo-occlusive disease will be more common in these patients than incidence of cirrhosis as per se.
And next question is, how to measure liver size in ultrasound, and is there any size criteria for shrunken liver?
There is no size criteria for shrunken liver. The size criteria which is most commonly popular is measurement of the right lobe length in a sagittal section, and people use 14 centimeters or 15 centimeters as the cutoff to call that this is a enlarged liver, larger than that. Some people also measure the anteroposterior thickness of the left lobe against the aorta, and if it is more than 5 centimeters, that is also used as one of the cutoffs. But we need to remember that we have not seen this patient before, so we don't know where he started. If he started at 10 centimeters and we measure it at 13 centimeters, that still is an enlarged liver for this person. So these are really a little vague cutoffs, and mostly it's a visual impression. Also, we need to remember that hypersthenic patients will have a elongated right lobe, and very often the query comes that his liver is palpable. So look at his liver on ultrasound, and what you find is a elongated right lobe. It's not really an enlarged liver, so that we need to. On the other hand, there are some studies which have tried to estimate hepatic volumes, but that is an extremely cumbersome procedure and it's not really practically used anywhere.
Okay, sir. The next question is to ma'am. Ma'am, is it appropriate to do a elastogram in a patient having oxygen and IV also?
I don't think we will be able to give very good data, because the patient will not be able to breath hold. If the patient is dyspneic, is on oxygen, if the patient can breath hold, yes, we must attempt. But if the patient cannot do a good breath holding, is restless, and an IV is something that will not be able to give us a good data. With respiration, you will have a lot of artifacts, And I don't think elastography will be able to stand a good chance of giving good results.
Okay, thank you. So next question is to you, sir. How to reduce the sampling error due to respiratory movements of patient during portal vein Doppler?
So, as I said, most of the time you don't need to do a spectral analysis of portal flow. It's more of a qualitative assessment, whether the portal vein is patent, whether it is flowing towards the liver, whether the flow appears good. But if you have any doubt, then you need to sample to look at the flow velocities. The flow velocities you can do in when the patient is holding his breath. There's no problem. Then there is no movement. But for respiratory variations, you will have to allow the patient to move and then check velocities in inspiration and expiration. And then you need to be a little careful about the angle corrections because the angles might change once the patient has taken a breath.
Okay. Ma'am, next question is to you. What are the cutoff values of spleen elastography and how can it help in diagnosis?
So spleen elastography has been a very recent add-on. So there are two studies, but both of them are having minimal variation. The cutoff is less than 16 kPa. This is which has come through the SRU. Less than 16 kPa would say that we are not having spleen. With the liver elastography gives us a consolidated idea about whether there is a presence of varices. So because the pressures, the splenic pressures increase and leads to formation of varices. So it has a significance in giving out whether there are varices. And if it is less than 16 kPa, we say that it could be just a clinical significant portal hypertension with no varices, but if it gets raised beyond 16 kPa, along with a raised F3 or F4 of the liver stiffness measurement, then we can make a very happy rule in that there could be presence of varices. And this is the way probably how the gastroenterologists are not going to like the answer. But when we are doing an endoscopy to rule out varices, this is a very wonderful rule in. If it's greater than 16 kPa, then there is a high probability of varices being there. So that's the significance of splenic stiffness.
Okay. So next question is to you, sir. What is the optimal angulation and flow frequency in color Doppler study of portal hypertension?
We use our standard abdominal convex probes for portal system assessment. We don't use any special probes for that because you are doing an abdominal scan basically. So you are using your standard abdominal convex probe. The angulation will depend on how the portal vein is coursing through the abdomen. So you don't might sometimes to look at the portal flow better. There are two ways. One is to go through the epigastrium and see the portal vein flow away from you, or to go through an anterior intercostal space and to see the portal vein flowing towards the probe. Either way is fine.
Again, the next question to you. Immediate management of portosystemic stent blocks.
Immediate management. I think that I will leave a pathologist rather than me doing it.
Okay, sir. So, there is one question to ma'am.
You can always, depending on what sort of blockage it is, you can always go in and cleaning procedure. When you are putting a stent there, you can always go in and do a here to clear that blockage if it's an acute blockage which is not responding to medical. The stenosis of the stent can also be dilated by going in again. But it will also depend on what comorbidities the patients have, why he has had a stent blockage in the first place.
So, ma'am, the next question is to you. What are the tips for extreme obese patients or narrow rib cage or poor window for elastography?
Yes, narrow rib cages, there will be definitely an error in taking out a good data. We can, of course, make the maneuvers like we can make instead of supine, the patient can be in left lateral decubitus. The arm goes up and we try and go into the widest one. So the angles of the ribs, the spaces, intercostal spaces between the angles of the ribs are always narrower. So we find a better window and see go on from 7th to 9th intercostal space. You can jump over that to see where we can find a good window. When it comes to obesity, the anterior chest wall always has a greater fat content. So you try and move a little more lateral or a little more posterior to find an adequate window. And the third one, Zenith, was?
Rib cage and obese patients.
Obese and
poor window. Poor window.
A poor window will need optimization. You need to optimize your images. You need to see for the depth. You need to see for your grayscales, and you need to adjust your TGC curves, which is like a part of doing a routine ultrasound. So optimization of the grayscale image is really important, because if you have a good grayscale image on B mode, you will have a good elastogram. This is something which cannot be overstated. But yes, when it comes to obesity, and when it comes to intercostal spaces, it does remain a big challenge. And yes, we need to modify our techniques accordingly.
Thank you, ma'am. And so there's a question that can there be a cavernoma affecting only a branch of portal vein?
I suppose so. That is possible, but will be very rare. That is possible. You can have occlusion and obliteration of one branch, like in Birchiri, we can have occlusion on hepatic veins. So that is possible.
And next question to ma'am, velocity or resistive index, which one is better for diagnosis of liver stiffness?
Velocity or resistive indices? Resistive indices where? I mean, what resistive indices we are talking of? Vessels? Because there is nowhere else. There are no resistive indices that we take in elastography. We just take the velocities or the shear wave elastographies in meters per second. And between the elasticity, if the person who's questioning meant between the Young's modulus elasticity in kPa and between the shear wave velocity in meters per second, definitely meters per second any day. So we can just make a more confident diagnosis if we put two parameters together. So we're putting the elasticity kPa, Young's modulus together with meters per second velocity shear wave, we can give a more confident diagnosis. But if we have just one isolated factor that we want to consider, then definitely shear wave velocity in meters per second.
Ma'am, so now the last question to sir. So is hepatic vena cava syndrome more common in India than Budd-Chiari syndrome? Any differentiating points on ultrasound or Doppler?
That gets me, and I'm not familiar with this name, hepatic vena cava syndrome. I suppose by that they mean the stenosis or occlusion of the intrahepatic part of the vena cava, and it's not a separate disease from the hepatic veno-occlusive, part of the same spectrum. And I am not aware of their relative incidence vis-a-vis one with the other. So I'm not very sure whether, but I in my practice have seen hepatic veno-occlusive disease more frequently than isolated intrahepatic vena cava occlusions or narrowing. And probably that will include webs in the terminal IVC as well. They are a little less common than the hepatic veno-occlusive disease per se.
Okay. So this is the last question was there. Thank you very much for this interactive question answer round also after the great presentation. I would like to extend my thanks to Dr. Sudheer Gokhale and Dr. Nidhi Bhatnagar for the wonderful sessions. And I would like to convey the vote of thanks to the viewers for joining us today for this webinar. Thank you very much.
Thank you, Zinath, and thank you, Team GE, for hosting this webinar. And I would like to say that we are planning more such webinars with GE for Asian Federation of Ultrasound. Keep looking forward to the months. That will be a program narration well in time.
Thank you, Zinath. Thank you very much, Dr. Gokhale, for sharing the platform. I enjoyed your presentation thoroughly. Thank you very much. And good night to all the attendees of this webinar. Thank you for joining in. Good night.
Good night, folks. And I hope you keep safe, even though the restrictions are getting lifted. Be a little more careful than you were before. Thank you. Good night.
Good night. Thank you very much.